We are live.
Yes. Oh,
Happy Thursday night. This is Renata, Angela, Dr. Anderson, and the rest of Airway Circle crew. You guys on Facebook don't usually get to watch the pregame. We log in sometimes a few minutes early. And we get to chat before
look
we
who's
start
here.
our live. Who's here?
Kimmy. She made it.
Kimmy, you made it, Kimmy.
Her daughter
So-
just graduated high school, like just a couple of hours ago.
No, this is the most dressed up I'll ever be for a Thursday live.
How are you feeling?
No, all good.
How was it? Was it pretty?
It was really good. Yeah. Nichole, you've been through this, or Dr. Anderson, sorry, you've been through this, you know.
Yeah.
Your son just graduated from UCCS, right?
He did, yes.
That's where my daughter's going.
Oh, good. What is she going to study?
Forensics and criminal justice for now.
Very
We'll see if she changes her mind, but I'm
Yeah.
like, are you sure you don't want to do this for your daughter?
Yeah, I had the same conversation with my son, but and engineering there's a lot of engineering that goes into dentistry. So
Yeah.
he's a great dentist, but he's an engineer through and through. He could not handle the people portion of our job. So he's
Good.
probably better off in just staying as an engineer. But yeah, it sounds exciting what your daughter's going to study.
Yeah, she just she loves all those like true crime, shows and like it sounds like your son like not great with the kind of like people management stuff.
Yeah, he just likes facts, he likes black and white, he likes math, he likes the whole like different personality stuff is not anything he wants to deal with. So
Yeah, good for him. Well, I'll shut up now, but I wanted to at least pop on and watch as much as I can live, and then once we go out to dinner, I'm gonna watch the playback because I'm so excited to hear you present tonight. Thank you.
Thanks
thank
for
you. Thanks for
coming.
inviting me. This is great.
Yes, I'm going to share now about on all of our groups. If we have any state leaders in the house, please accept my share or share it for us. And also do not forget to delete after, because I delete the live after it goes live because it's free for everybody to watch a live Hey Medicine. And then it goes into our membership. So if anybody, after I delete from Facebook, it shows an empty post. So it's a bunch of empty posts. People don't know what that is. So if you're a state leader, please delete those as they come in, so the Facebook groups do not look too crowded with that stuff. What else was I gonna say? I heard about a couple different companies. I'm looking at my phone because I'm sharing. I heard about a couple different companies today, and I just wanted to ask if people knew about them. One is Empower Sleep. Oh, I deleted the other one, but it started with an F. Rest Assured, I think, is one. These are all home sleep tests. Has anybody worked with them or heard about them? One of them started with an F, and it was the best one. I can't remember the name of it now. But anyways, I know there's several companies out there that will send sleep tests for their patients. It's always good to find out which one works better. Not only by sending the test, but like afterwards, the physicians that are reading this and the kind of customer service that they get afterwards. If anybody knows, let us know. You guys all know that I'm a big fan of Wesper. You can't see that I have their bottle. I'm a big fan of Wesper. Has anybody used Wesper over here? They are now FDA approved, and they have a finger probe that you can wear. And it's just stickers. You change the stickers every night and you put them on. We all know that one night sleep test does not work. So that's cheap enough that patients can buy and they can monitor themselves. So it works pretty well. I just wanted to know if anybody has experience with those. Another thing I wanted to say to you guys is we got the sweetest message ever. And everybody shared that with me on Circle Time. Do you remember, Ange? It was from a surgeon, a maxillofacial surgeon. He does some MMAs. Here he is, his cases. from Brazil. And it was Dr. Tomás Fleury that spoke for us, that mentioned Airway Circle. So he joined, he became a member, and he wrote the sweetest message saying that he wants to, he can, he's learning a lot already with our lives. Here he is, if anybody wants to follow him. And his cases are pretty good. You guys want to see it? But Dr. Pablo, very, very interesting.
Renata, do you want to share one of his posts on Instagram? And that way everyone can check out your Instagram page and then be directed to that link right there?
Yes, I'll do that. And then the last thing I'm going to say before we start. Intro to Airway. Oh my gosh. You guys have no idea what this course is going to be like. We're, the lectures are coming in and we're putting it together. And every time that we go in there and we look, we go like, oh my goodness, the speakers. Should I release some of the speakers right now? Because nobody knows who all the speakers are. Here, let me tag everyone, and we're going to start in a second. Let me tag everyone on our Facebook group. Really
Renata,
quick.
while you're looking for that, Kimmy, did you get my note? Just checking. Okay, perfect. Thank you.
Everyone, I know everybody's excited to hear your talk, Dr. Anderson. Listen up. I know everybody gets so upset about everyone. I'm sorry, but it works. I mean, we get like 30 extra people, and they are happy. They tag them. So if you don't like it, just scroll, keep scrolling. All right, I'm gonna release some of the speakers. Ta-da-da. Let me just pull it up so I know. Guys, it's insane. It is insane, the people that we have here. It is such an amazing course. There's so many big, amazing courses out there, but you never know where to start. We wanted to do something that was very comprehensive, but, initial for anybody in this field. Dental hygienist, speech pathologist, dentist. So many dental offices want to become airway, sleep, and implement myofunctional therapy, and they don't know how. This is the first step to train the whole staff. You start with intro to airway, and it's not expensive at all, which we're just talking about it today. And we're going to have to up the price because the caliber of speakers that we have is just absolutely insane. All right, guys, ready? So it starts with fundamentals of airway, which is Angela's 2 lectures. And that is like already, it kind of like pulls everything together, and then we're going to break it down. Why breathing matters. I won't release that one yet. The orofacial complex, you guys can imagine who that one is. We have Christy Gatto and Amanda Chastain. We're going to talk about dental anatomy. Tamara is talking about that. I don't know if I should release that one either. Breastfeeding, we have Melissa. How do you say her last name? She's from ICAP. And then we have an early feeding development with Tony Ann Antoniato, and Janine Steen. Nauseous and prolonged oral habits, also with Tony Ann. And then we have sleep disorder breathing. Are you guys ready for sleep disorder breathing? Da-da-da. Dr. Steve Carstensen is one of our speakers, and the other one is Dr. Gerald Simmons. What? I mean, just for that is enough. And they are going to give you everything. I mean, Dr. Steve is a dentist, so he's going to give you all of everything you need to know in the dental office when it comes to sleep. And Dr. Simmons is going to give you all of the sleep physicians, portion of what you need to know whenever you're collaborating. Is there a camera that's like on, but it's dark in here? There you go. So what else? And then we have myofunctional disorder. It's going to be Anne. And then we have the essential role of the orofacial myofunctional therapist in the treatment of dental facial and airway problems. This is going to be a bonus, I think. It's Nichole Goldfarb. We love her. She's the best. And then we have a physical therapist perspective into airways. So if there's any physical therapists over there, this is going to be amazing. And that's Nichole Goldfarb's husband. If you guys have not had the chance to meet him, he's fantastic. Then we have 3 bonuses right now. Dr. Karen Davidson is going to be talking about nasal resistance and how to measure it. How to implement myofunctional therapy in the dental office is going to be medicine. There she is. And maybe Kimi's gonna do a little bit of that too. An intro to the myo brace system with Dr. Paulo Suarez. It's insane. It's like the basics of everything you need to know. There's one more thing that I want to add that I really think we should have in there, and you guys probably can guess what that is. You can put on the chat box, and I'll tell you, you guys, if you guess what is missing out of there. I have one thing that I really want to show, but I'm looking for a speaker. So if we can do that, we're gonna put it together. But I'm so excited. Did you guys put the link on the chat box? Is this all?
I'm grabbing it right now.
This is all intro to airway. So there's another portion of intro to airway that is 3 hours, because these are your 1 to 2 hours. So easy to watch. Everything is recorded. There's another portion of intro to airway that's going to be Roger Price and Dr. Bahar Smiley. If you guys have heard him speak, fantastic. And then the other portion is going to be, and it's all included. It's going to be Dr. Baxter and Robin Walsh. Come on, talking about thoughts. So they're doing this live course for us in June, on the 27th of June. And you can just purchase a live course if you'd like, but if you don't, you can get intro to airway and you get all of it. So pretty incredible. We're very excited. But yes, it's right there. And after June 1st, it is gonna go up. There's no way that we can keep intro to airway at this price with these people. It's in the classes that are coming in, they're just insane. I'm gonna stop talking right now. And who would like to introduce Nichole? Anybody has it pulled up?
I have it up.
Okay, go for it, girl.
Awesome. So Dr. Anderson has been in dentistry since 2001 and has worked from front desk staff member to a hygienist and myofunctional therapist. And she knew her airway journey was incomplete. So after completing her dental school at CU School of Dental Medicine and a GPR at Denver Health Medical Center, she now practices as general dentist, focusing on addressing airway with frenectomies, mandibular repositioning devices, and myofunctional therapy. Dr. Anderson is also an expert in the etiology and treatment of airway and myofunctional disorders and lectures nationally on the topic. She owns and operates the Institute of Orofacial Myofunctional Therapy, where she teaches other licensed providers how to integrate the therapy into their practice. We are so excited to have you. I just know, like, you have just such an incredible, unique journey and story. And I think your perspective on just airway focused collaborative treatment is incredible. And so we're super excited to have you.
Well, gosh, thank you so much. I'm really excited that you guys asked me to talk. I will try to share my screen. I haven't done this in a while, so I hope it works. Let's see here. Oh, yeah. Let's try this. Thanks for bearing with me. Okay. All right. Can you guys see this?
We can.
Okay, great. All right. Well, so yeah, what Kimmy was saying, I guess I feel like I've just lived a couple different lives because I actually started out in retail. I was in retail management and I did visual merchandising for department stores and retail stores. And I then was divorced and I have a little 2-year-old son. And when I stayed at home with him when he was little, but then when I got a divorce, I went back to work and I went back into retail. And it was pretty quick that I realized that was not conducive to being a single mom of a little guy. So I went to work for a dental office. I just answered an ad that I saw actually playing on TV. There were some ads playing on my TV and I reached out to be a front desk support staff. I did not know anything about dentistry. I was 26 at the time. And we really never even went to the dentist very much when I was little. So I didn't know the difference between a hygienist or an assistant. And I thought at some point I might want to go to medical school. But again, with my son being so young, I didn't think that was going to be something that I wanted to do. I didn't want to spend that much time away from him. But as I worked at the dental office, doing front desk, I learned more about what the hygienist did. And I thought, well, that's actually a really great career. And it won't take me 12 plus years to become a hygienist. So I can still devote my time to Matthew when he was little. And so I moved back down to my mom's house. I moved in with my mom and went back to school full time and did my prerequisites and got into dental hygiene school. And after that, then I discovered myofunctional therapy. And instead of going to medical school, I thought, well, I guess it would just make more sense for me to go on to dental school. And this is one of the things I encountered when I was in hygiene school. I'm going to try to move this around here. So I had a patient that presented this isn't the patient that I had, but the patient presented very similarly to this anterior open bite. And I was pretty fascinated by the growth and development of this patient. And the supervising dentist that we had at the time, he was actually a periodontist, and he just described it as maxillary hypoplasia. But I kept wondering, well, but why? Why does the tongue keep sticking out every time she swallows? Why can she not really articulate her words very well? And the supervising dentist wanted to refer her to a speech pathologist and an orthodontist. And I thought, well, okay, but something in there still didn't seem to fit together for me. But I didn't know anything about this occlusal scheme and the etiology of it. And so then I started working as a hygienist. I graduated in 2006 with my associate's degree. And you deal with all the tongues, right? All the tongues that just can't seem to get out of your way. And that's the one thing I think I disagree with a lot. I see people who are talking about myofunctional therapy and they talk about strengthening the tongue. And I think for all the hygienists out there, we all know that the tongue is already strong enough. We don't have to strengthen it. We just need to coordinate it. We need to educate the tongue so that the patient actually has control over it. So dealt with all the tongues, dealing with all the tight mentalis muscles when you're trying to scale the anteriors, the gag reflex when you just barely have the mirror in the mouth. That was actually one of my screening tools when I started doing myofunctional therapy. I knew right away if they were gagging on a simple bite wing that something was going on with their airway. And I saw a lot of ortho relapse, saw patients with TMD because their muscles were not balanced, and then a lot of open bites, anterior open bites, and then unilateral and bilateral open bites. This is one of the patients that I saw. This is actually after I became a myofunctional therapist, but I always like to show this one because this patient here had ortho twice. And you can see he has the anterior open bite. He has the lingually tilted teeth and high narrow palate. But then you can also see that he has quite the deviated septum. And he was a bacteriophobe. He was a germaphobe. So he was at the doctor at least once a month. He always wore gloves. He was scared to touch anything because he didn't want to get sick. But all those doctor visits, and no one had ever identified him as having a deviated septum. I actually referred him to an ENT and they ended up doing surgery on him. But, look at all the years that he had to live, obviously not breathing well through his nose, mouth breather, and all those years going through expensive ortho and still not retaining the result. So how I came into myofunctional therapy, though, was one of my hygiene instructors. It's in the middle picture there. She's the one over to the right. She was one of my hygiene instructors, Candy Learned, and she called me up one day and she said, I have this training that I think you would be interested in. And so we talked a little bit more about it. And the other two girls there, I'm the one that's second from the left there, but the other two girls, they were also hygiene colleagues of mine. So she introduced us to Sandra Colson, and we went up and we took her course. It was in 2008. It was an IAOM track course. I am not a certified orofacial myologist. And if anyone wants to talk more about why I'm not, I would be happy to share that also. But we spent a long weekend with Sandra and learned how to incorporate myofunctional therapy with our patients, what to look for. I think it was still kind of a newer situation, like really going into all the airway disorders that we have nowadays. Because we talked about airway, but we focused more on just really the oral complex and not so much on the nose and nasal arena. And it wasn't really until I went and completed my bachelor's degree, and I actually used the serotonin and the dopamine response with stimulation on the palate to do research for one of my research projects. And that's how I found out about nitric oxide. It was really before everyone was talking about nitric oxide. Anyway, so it was still like a work in progress, and back in 2008, and I started lecturing on myofunctional therapy. And at the time, it was just called orofacial myology. We didn't even call it myofunctional therapy at the time. And I did myofunctional therapy through my dental office, and I actually had orthodontists referring patients to my dental office for me to do myofunctional therapy. And then people just kept hearing about what I was lecturing on, and I kept thinking that I was probably going to get out of doing the myofunctional therapy, mainly because I was trying to go to dental school and I was trying to complete my prerequisites, and my son was getting older and he had sports, and it was just a lot to juggle. And I thought, well, I don't know if the myofunctional therapy thing is really going to have a place in my life anymore. But people kept asking me to come talk to them. So I would go talk to orthodontic study clubs and dental study clubs. And I even went and talked to a graduate program for teachers getting master's degrees in special education, because we were talking about how nasal airway and nitric oxide can, the lack of that can actually be associated with developmental disabilities and learning disorders. And so I just kept kind of getting drawn back into it. And I completed my bachelor's of science in healthcare science at UCCS at University of Colorado in Colorado Springs. By the grace of God, I graduated summa cum laude, and I had university honors. There was a lot going on in my life. So to this day, I'm wondering how I got a high GPA that I did to get into dental school. And I actually did my honors capstone project on the identification of myofunctional disorders. So of course, I'm lecturing to all these non-dental people in UCCS, to, the younger kids who are like in their 20s that have no idea what I'm talking about. But I was just so passionate about it. It was involved in everything that I really did since I learned how to do the therapy. So as I kept lecturing on myofunctional therapy and airway, I decided to just start my own business doing it out of the office building. And I first created or started the Institute of Orofacial Myofunctional Therapy to treat patients, because, well, as we all know, there are so many patients who need it, and there really wasn't anybody doing the therapy. So I got back into doing the therapy for patients. And then every time I would go and talk about myofunctional therapy to groups, everyone thought that they were going to be learning how to do the therapy. So they were, I don't want to say they were disappointed, but they always just wanted more and more, and they wanted to know how to do the therapy. And so I thought, well, I guess I might as well start teaching people how to do the therapy for their patients. So I created a 3-day course, 28 CEs, and it's PACE and AGD approved. It's nationally approved, so anyone from any state can take the course and get CEs for it. And I'm currently working on an online course so that people can take it on demand. So these are just a couple pictures of some of the classes I did. I actually did these classes while I was in dental school. And sorry, my phone here is ringing. In fact, I think one of our attendees, Dana Moon, she's in this top picture here. She was one of my first students. And actually later I went on to work with another person who took my course. And so that was kind of neat. She was a myofunctional therapist and I was a dentist in her office. So that was really refreshing to be able to work with someone who really understood airway. Then when I was still in dental school, I actually got a call from someone from the RMDC, Rocky Mountain Dental Convention, which is our big dental convention here in Colorado. They wanted me to present on the etiology, and well, they wanted me to present on myofunctional disorders. And so the title was the etiology and treatment of airway and myofunctional disorders, because I want everyone to understand that that airway is the part of the issue. So it's not just these muscles don't know what to do. They don't know what to do because the patient is not getting the correct amount of air in the right way through the nose. So I was still in dental school at the time, and I ran it by the Dean of Academic Affairs. I think that was what his title was. And I just wanted to make sure that they were going to be okay with me presenting at this conference where they were all going to be. And they said it was fine that I presented, but I could not mention that I was a dental student, and I couldn't mention anything about the University of Colorado School of Dental Medicine, because they didn't want people to think that they were endorsing what I was talking about. Well, they ended up moving me like 3 times to different rooms because more and more people started signing up for my lecture. And so I ended up being in like the biggest room possible, standing room only. And so it was just really exciting to know that people were interested in this, because as a hygienist, one of the things that pushed me over to going to dental school, because at this point I was kind of tired of going to school and, dealing with life and everything. So I thought, well, maybe I don't want to go to dental school. But one of the things that pushed me over and just got me into dental school, pursuing it, was that, all these dentists that just, number one, didn't, and it wasn't really an ego thing. It was just, I was so frustrated that they didn't take me seriously. And I would be trying to point out that, yes, this patient with an anterior open bite does need to go to ortho. However, they also have a Cotlow class 4 tongue tie, and they just weren't seeing it. And I just felt like as a hygienist, they didn't really respect me enough to really want to listen. And I even tried to go talk to an ENT once about my nephew, and he didn't know what a dental hygienist was. And so there was a lot of discouraging moments as a hygienist doing myofunctional therapy. I had a lot of really great dentists who happened to be older, and I think they had been in practice long enough that they knew that there was a dynamic situation that they couldn't solve, because they would see that the ortho was failing. They would see that their pros work was not successful. And so the older ones tended to really understand the connection that I was trying to talk to them about with their patients. So, to be invited to speak at this huge convention and to have so many people interested was just really exciting. I was really surprised. And plus, I had been so engrossed with dental school that I was just surprised that the Airway had been getting the attention that, it finally deserved. So that was really exciting. I was still in dental school, and I went and I flew out to Los Angeles for the day and got my OMG certified. And then, being in dental school where I was, we shared a campus with the Children's Hospital and also UC Health. And we also had an orthodontic program residency. And so I reached out to the ortho program 3 separate times to see if I could do research with them. And being in an academic environment, I thought for sure that they would want to be on the cutting edge of what was being talked about, that they would want to be interested in airway and how this affects growth and development. And they turned me down all 3 times. They were not interested. I was just shocked at how uninterested they were in this, especially because we did have the Children's Hospital right there. So we could do research with nursing. We could do research with the pulmonologists at the UC Health Hospital or the respiratory clinic or the allergy clinic. And, as much as I tried, they just were not interested. And I really couldn't talk about airway because, number one, I was a student, so nobody thought I knew anything, which is, that's fair because I was a student. And I did manage to, kind of dig in a little bit, some of the airway here and there, mainly because I didn't want my classmates getting out being dentists and being the kind of dentist that I had worked for, where they weren't seeing the signs of this, the growth discrepancies and the respiratory complex and how that was affecting dental development and craniofacial respiratory development. So I found a way to, kind of get the word out there. And so even though I really couldn't talk about it much, I did do a presentation on, it was a systematic review and meta-analysis. So the highest level of research. And this is what sparked my attention to do this research project was this case study that Dr. Gamino did on as a comparative study on the death, the nasomaxillary complex and sleep in young children. So I'm thinking you guys have probably all seen this, but you know, it was the death of 7 children, and they were all previously healthy children that died in their sleep of hypoxia. And the only thing that they all had in common was the same high narrow palate and narrow nostrils. And they all had signs and symptoms of sleep disordered breathing that had gone unnoticed. And this little baby there, you can see that is the way this little infant was sleeping. And they took a picture of this infant, and the parents did, and showed it to the pediatrician. And because they wanted to know, why is our baby sleeping like this? And the pediatrician didn't have any answers. Well, it was determined that the lymphoid tissue was so enlarged that was the only way that this baby could get air. And then the baby ended up dying. I think he was 8 months old at the time. But this was the systematic review and meta-analysis that I did my presentation on, and it was myofunctional therapy to treat obstructive sleep apnea. I don't know if any of my classmates ever really paid attention or cared much, but you know, I was hoping to hopefully, you know, instill this in them so they had it in their minds as they went out to practice. And then this was one of the patients. She's actually a good friend of mine. She was a couple of years under me in dental school. And one of my faculty members, though, he really supported me, and he referred her to me to do myofunctional therapy on her. So she was a nurse and then went to dental school. And you can see that she's got she had a bilateral posterior open bite, long mandibular plane angle. You can see how narrow her nostrils are. And she actually had 2 sinus surgeries, but and she was great. We started therapy, but COVID then happened, and we were actually never able to finish therapy. She did complete braces. I haven't seen her in a while, but every time I see her, you know, I always try to check out her bite, because I did warn her. I said, you know, we haven't retrained your tongue yet. It was her tongue. She had a posterior tongue thrust, and I told her, you know, you're probably going to get that posterior open bite back, but anyway, so that was kind of neat that one of my faculty members did actually refer a patient to me. And so then I finally graduated, and I went on to do a general practice residency at Denver Health, and it was the best year of my life. I loved every second of it. I wish I could have stayed there longer to do maybe another year. So it was a great experience. I loved being in the hospital. I loved being in the OR. I got to do all of that, and got a lot of great experience. But similar situation, really no one understood Airway, and I was there to learn. So I really didn't have a lot of energy trying to talk about it. You know, I was trying to get a different skill set in terms of being a dentist and actually doing dentistry. So I didn't really invest a lot of time trying to talk to my attendings about it. But I did have a pediatric attending, because we had a pediatric rotation that we did, and she was very supportive of screening for ankyloglossia and lip ties. And so we were not able to do the frenectomies over there, though, in the pediatric section. We would refer them to the oral surgery residents. And the oral surgeon, I remember this one oral surgery resident came and talked to me, and he said, why do you keep sending us all these referrals for frenectomies? He goes, they don't need them. And I said, and he and I kind of went head to head about it. And by the time we were done, he didn't have much to say, because everything that I said finally was making sense to him. And I was at the point where I was kind of tired of being quiet about it, because these poor kids needed help and they weren't identifying it. And so I wrote a letter to the oral surgery, he was the attending, and I explained to them, because how they were screening for these tongue-tied and tongue ties really was if they could stick their tongue out and lick an ice cream cone. And I said, well, I respectfully disagree with that, because it doesn't matter if they can lick an ice cream cone, that they can protrude their tongue. Can they elevate their tongue? Can they get their tongue on their palate so that we get proper palatal development, so that we get proper nasal development, so that we can get the proper filtration, so that we can have enough nasal airway space. And I quoted, you know, there was a lot of research in there that I sent to him. Never heard back. He never addressed the letter even. And, but luckily I did have that pediatric attending. She was supportive of me. And then also I went on to present for the California Dental Association while I was in my residency on airway and myofunctional disorders. And that went really well. And even though I couldn't talk about really airway, it's not that they were like completely against it. They just didn't really understand it. And I did actually do my grand rounds presentation on the etiology and treatment of my airway and myofunctional disorders. And I really talked a lot about nursing and how, the actions of the muscles and how really all the research that I had done goes right back to nursing and how important that is. Of course, there's a lot of different factors involved, especially nowadays, with epigenetics, but, and every time I see a pregnant patient as a dentist, I always encourage them to, if they can, if their job allows, if their lifestyle allows, to really try to nurse. So then, while I was still in residency, I flew out to Spokane and got trained in doing my own frenectomies. It was the most exciting time in my whole life. And I was so excited to actually do my own frenectomies because I had had so much pushback from dentists on what they thought needed a frenectomy. Of course, I wasn't actually doing this on an actual human being, which is totally different, doing it on a squirmy little infant or a 4-year-old child or an adult. But it was just a really great experience. This was the light scalpel CO2 laser. I don't use a light scalpel, but it's a really great laser. So finally, I was able to do frenectomies, and this is one of the patients that I saw a couple weeks ago. So I work 1 day a week in Pueblo West, and we see tons of kids. We do not refer any kids out. We take them to the OR if we need to. We do everything on these pediatric patients. And this little one was 5 years old. She's in kindergarten. And like I say, we see so many kids there. We get referrals from other offices to come to our office. And so we are used to all the different articulation styles of pediatric patients, and we could not understand anything that this little girl was saying. And so part of the problem was she was lip and tongue-tied. And I ended up doing both upper and lower labial frenectomies and a lingual frenectomy, and her dad said that she was starting speech therapy later that week, so that was good. So we had covered some bases there, and she healed up. I don't have the 1 week follow-up, but she healed up great. I never really have an issue with the kids doing the exercises because they're so fun. I do have an issue with the parents or the adults doing their exercises, and actually I really don't release a lot of adults unless they've had maxillary and mandibular expansion, mainly because the tongue doesn't have any place to go and you can create airway issues. So I really very rarely release adults. This is one adult that I released though, and I released her just Monday. Actually, this was Monday. So she had gone to a periodontist. She had been going through braces. She had braces a couple times, and she was finally going through Invisalign. And she, her orthodontist actually identified that she was tongue-tied. So I was really happy to hear that. And he referred her to a periodontist. Well, the periodontist did the lingual frenectomy, but he did the Z-plasty, which was fine. And he only put a couple sutures in that didn't last. And he didn't give her any myofunctional exercises to do. So as you can see, she reattached with scar tissue. So she came to me and I released her, and I actually sutured her up to avoid having any reattachment. And I always have my patients do 2 weeks of myofunctional therapy exercises prior to getting the release, and then 6 weeks of exercises afterwards. I'll be honest, I really don't do the myofunctional therapy anymore, mainly because I don't have time in my schedule. And so I'm trying to refer to other myofunctional therapists because these patients do need it, but I at least give them exercises to do, just at least so we can avoid getting reattachment. And I hope no one's judging me on my frenectomy here. I do use a Waterlays MD erbium laser, but I kind of went to town on her because I, number one, had a lot of scar tissue to get through, but also I ended up undermining the tissue with blunt dissection with the hemostat because I really wanted to release her so that she wouldn't have to go through this again. So it looks a little messy, but I sutured her up. And she's doing great. And I always send my patients home with Arnica Montana to use, and it helps. this is one of the little infants that I released, and she was my first infant release. So I don't have any before pictures because I literally was sitting in my office, giving myself a pep talk and almost on the verge of tears because I was so nervous. She was so tiny. She was 3 months old, but she was underweight. She doesn't look underweight in this picture, but she was underweight. And the mom reported poor latch, painful nursing sessions, and the baby really was not gaining weight. She wasn't thriving like she should have been. And she had been diagnosed with acid reflux. She wasn't on medications, but she had been diagnosed. And so I don't have any before pictures, but she was overattached. Her maxillary frenum was overattached. She did have a little bit. She was probably a class 2, a Cotlow class 2. She was probably 3. I don't have pictures, so I can't remember, but I was more concerned with her lip tie. So I did both a lingual and a maxillary lip release. And the mom, I always let the babies nurse immediately after. Number one, to make the mom feel better, make the baby feel better, and also just to get the muscles to work correctly. And the mom immediately said that there was no pain. She could tell a huge difference even just right after we did the frenectomy. So that was the most rewarding frenectomy I've ever done. Was my first infant. And then Bialys actually had me go out to I think it was Austin. I can't remember. It was somewhere in Texas to present to their pediatric dentist on the importance of incorporating myofunctional therapy when you're doing frenectomies. And so that was exciting to do that. And I'm also making airway appliances. And this guy here, his AHI was, I want to say in the 90s. He was beyond severe, and he has a CPAP, but he's got protrusion of the tongue. He's got some issues. He needs we're starting myofunctional therapy, but we haven't gotten very far, mainly because he's kind of having some pushback. But I did get him in a mandibular repositioning device, and I don't have a before because I always, the way I take my measurements, I always lean them back. I have an airway metrics system where I'm able to really figure out what position to put them in for ideal airway when they're sleeping at night. And so this is before, this is after, this is when I'm delivering his appliance, but I'm telling him to give me a snore. And if you listen, you really can hardly hear anything at this point.
Yes.
So you can hear a little bit of a purr, but compared to what he was doing on his back without the appliance, it was like night and day. So, so I was really excited to deliver that appliance. I do a lot of these appliances, a lot of different ones depending on the situation. This was an appliance for a patient that has a little hole for the tongue, an Essex retainer on the lower arch so that we can prevent any super eruption of the teeth. But this helps support the mandible forward. It's not locked in like the Herbst appliances though, but it's still successful depending on the patient. I also do TMD appliances and neuromodulators like Botox. So this patient here on the right, she presented with signs and symptoms of right anterior disc displacement without reduction. She reported she was eating and she heard a loud pop. This was like about a year ago. Reported a loud pop, and she could tell immediately that her bite was off and her opening was limited. And so we went ahead and did a CBCT, and I sent it off to beam readers to get a formal radiology report. And so she did have, MRI really is the best imaging to see where the disc is, but through the CBCT, they could pretty much tell what was going on. So I put her in this appliance again with the Essex retainer on the bottom to avoid super eruption of the teeth and bite changes. But this appliance here will just open up her condyle from the articular eminence and from the glenoid fossa, And what we were hoping to do is just to recapture the disc. If we weren't going to recapture the disc, I was hoping that we could at least get some remodeling of the tissue to get a pseudodisc. But within a week, she said she heard another loud pop, and then all of a sudden her bite was okay, and she could open up all the way. And she hates this appliance though, unfortunately. And I think it's the patient, because she's just a very high maintenance patient. I also did Botox on her to help relieve the muscles. And so the Botox was very successful. The appliance is very successful. She's just a difficult patient. She actually ended up moving down to Florida, so I won't see her anymore. But I told her, really, she has to wear this appliance for 12 months, 24 hours a day, obviously not while she's eating, but other than that, anytime she's not eating, she needs to have this appliance. And because we recaptured the discs successfully based on her signs, based on how she's presenting clinically and what I'm seeing, but we need things to stabilize. So that's why she's got to wear it for as long as she does. I do Invisalign, and I don't do any IPR. I only do expansion. And so, I'm certified in Invisalign, but I also have taken some courses on doing clear aligner therapy for airway. And so this is an example of one of my clin checks. So as you can see, this patient has a deep bite, narrow arch, lingually tipped teeth. And so this is the clin check that I created for him. So you can see before how locked in he is, and how narrow. And then he does have 46 trays. He has to go through those. So he's going to be in Invisalign for a while. He does have some spacing, but our main concern really was just really opening up his arches. So, and even if that means tipping the teeth, you're at least giving the tongue more space. And we can always work on those spaces later, either restoratively or through refinements. So right now, when I got out of dental school, and I just found that everyone was talking about myofunctional therapy and airway, because I had been so focused in dental school that I really didn't realize how much it had taken off. So that's really good, because there's a lot of people who can do myofunctional therapy now. A lot of people are looking at the airway. And I obviously am still doing that, but I'm also really focusing on surgery. I love surgery. I think if I had gone to dental school a little bit earlier in life, I would have applied to an oral surgery residency. But luckily, as a general dentist, I can do everything and then just refer out anything that I don't want to do or feel is outside of my scope. So this was a failing endo-treated tooth that I extracted last week and placed an immediate implant. And so that will integrate for at least 4 months before we load it with the restoration. But the patient was very happy. I also extract impacted thirds. And so that's exciting. I love doing that also. Ideally, they would have room for their thirds, but as we know, this is not an ideal world. I'm also doing more extensive grafting. So this is a bone block graft that I'm doing for a patient who wants implant retained. She actually wants an all-on-6, but we're walking her through the stages of just getting implants in, because she has been a dentist so long. She really has very, very narrow, short ridges. So we are building up her ridges to place implants, and then eventually she will have implant retained dentures, and then we will convert her to an all-on-6. And then, of course, always dealing with complications. So this was a failing implant that I saw in my office. I didn't place the implant, but it was mobile, and so I had to take the implant out. I did a bone graft and non-resorbable membrane. And still dealing with frustrations. This was a CBCT that we took in my office of an 18-year-old boy. I didn't see this patient clinically. I just was going through our list of CBCTs. I was screening the images to, look for pathology. And I came across this one, and so I immediately figured it was just hypertrophy of the palatine tonsils, but I sent it off to beam readers to get a formal radiology report, which is what they confirmed. So not only does he have very narrow airway, but he also has enlarged right turbinate. So I called the mom. The mom didn't even know who I was because she always sees the other dentist that I work with, but I told her who I was and that I was concerned, and I sent her a screenshot of his CBCT. And so she went to see an ENT, and the ENT said, well, he doesn't snore and he doesn't have any symptoms, so we're just going to not do anything. And I'm all for leaving lymphoid tissue if you can on pediatric patients, because they're still establishing their immunity, and it's important. They need that. And so it's not uncommon, as we all know, for the lymphoid tissue to get enlarged. But we also know that snoring is not always the symptom that we'll see, or the sign that we'll see for an airway problem. I would have loved to have seen him clinically to see like what his arch, how his palate looks and how he was presenting clinically, but unfortunately I've never seen him clinically. But that was kind of frustrating for me to see that the ENT wasn't concerned. But we're also doing celebrations. This is my son who just graduated from UCCS last week, 2 weeks ago. And it's interesting. I realized that that's exactly 10 years to the month that I graduated with my bachelor's degree. So that was exciting. So moving forward, as now that I'm a dentist and I can do more than I could as a hygienist, I just feel like I'm kind of like a rabid dog that just got left off the leash. And so I'm trying to learn as much as I can. And really, I'm just excited to be able to do so many other things now. I'm completing a Women in Leadership certificate through Cornell University. I'm on my last course for that certificate program, and it's awesome. Any women out there who are interested in learning more about, women in these other leadership positions, it's been great. It's not rocket science, but it all makes sense and fits together. And it's just nice to have all of this formal education on really how to be a successful leader as a female. So I can't say enough good things about that. I'm presenting at the California Dental Association again in September. So they want me to come back down and talk about airway again, do my same airway presentation I did for them back in 2021. I'll also be presenting on epigenetics and its surprising role in pathology. I will be presenting on female to female dynamics in dentistry. We all know how interesting of a dynamic that can be. So that's another thing that I'm going to be touching on. And then also I will be talking about lasers in dentistry. I've done a lot of research in lasers when I decided which one I was going to buy. And so with all that research that I ended up doing, I'm going to educate other dentists. I spelled his name wrong. Sorry, but I will be taking Dr. Moralia's and Dr. Kevin Boyd's courses in October. I'll be learning more about the BioBlock appliances and pediatric growth and airway. Oh gosh, I typed this like really quick right before the presentation started, so sorry for the typo. So I'm really excited to do that because I have been working so hard on surgery and doing implants and bone grafts and stuff that I really want to start getting into more pediatric growth and airway, because we do see so many pediatric patients at my one office. And the dentist I don't refer to him, but the dentist that the orthodontist that the other dentist refers to, he still does extraction and retraction. And I can always tell when I'm examining a patient who had ortho, I can tell you immediately which one has seen the orthodontist, because they're missing their premolars or they have huge airway issues that have not been addressed. But it doesn't help that the orthodontist himself has a huge airway issue. I knew it immediately when I met him. So anyway, so it'll be nice for me to actually start treating the children earlier and actually addressing their airway. And then I'll be taking an implant maxi course. So, and getting certified in implantology. So that's about it. I don't know if anyone has any questions.
Ta-da! That was fantastic. You are a superwoman.
Oh.
How did you do this all? This is insane.
Oh, thank you.
We did have a question from Dr. B. He was asking, how do you manage a 2-year-old when doing frenectomies?
Well, I have really great assistants, and we are actually I don't want to say certified. We are able to use papoose boards at my office. Mainly, it's well, as we know, it's really a safety issue. But a lot of times, if we have them on nitrous and we have a little cartoon in front of them, the laser's so fast. A lot of times we don't even have to do that. I think I've had to use the papoose board once, but other than that, I have really great assistants. I'm just as fast as I can be, and we have them relaxed on nitrous.
Amazing. Do you mind closing off the screen so people can see?
Sure, yeah.
Thank you so much. Everybody is very impressed with your career and how inspirational you are. I'm a single mama, so I know how difficult it is, and I cannot even imagine going. I've always wanted to go to dental school, but I can't do it now.
Well, so how old are your kids?
Zoe's 8, almost 9, and Benny is 3.
Yeah, I know. I was in turmoil for, it's hard balancing it all.
Very good. Let's see. Are there certain patients who are not considered frenectomy candidates?
Yes, adults that have narrow palates, I don't think they're frenectomy candidates, mainly because the tongue is not going to know where to go. I will only do a frenectomy on an adult when they have had expansion for both the upper and lower arch. Well, I'm sorry, I will also do it if it's creating like recession on the lower anteriors, but that's a case by case basis.
Awesome. Does CMJ clicking always suspicious for disc displacement?
Well, the clicking that you hear is the disc, is the condyle jumping over the disc. So that means that the disc is not where it's supposed to be ideally. It doesn't always indicate that the patient needs appliance therapy. There's there are a lot of patients who will have clicking and popping, mainly because, they might have fallen on the playground when they were little and dislodged a disc and they didn't know it at the time. And then as they get older, things start to manifest and surface. But a lot of times, I don't need to do appliance therapy unless they're in pain or unless they've had a closed lock or an open lock.
Awesome. So I'm so happy with all. How can we assess whether a patient referred to us for myofunctional therapy has a displaced disc, or if the discomfort they're experiencing is more of a myalgia?
That's a good question.
That's
So I always, feel their jaw as they open and close, and I watch their midlines and I see how they're tracking. I see if they're deviating. If they're deviating off to one side, then that's a sign that they have a disc displaced. So that's one thing to look for, get behind them and see where their chin tracks. And then I always, one of the things that I always look for is, I will go in. I also do a TMJ release on all of my myofunctional patients, and I do it on a lot of my dental patients too, but I'll go in and I'll release on the certain pressure points where the origin of the medial pterygoid is, and then the pharyngeus and the insertion of the medial pterygoid, and then the lateral pterygoid. So if I put pressure on those and they're having a lot of pain, they're on the ceiling because it hurts so much. Well, I know then at least there's a muscle component involved. Or I can feel like on their temporalis, if there's like guitar strings there, then I know that they're having issues. And it, a lot of times it can be a combination. So in terms of whether or not it's a disc problem, I always feel and listen to see what the joint is doing with that disc. And then I'll palpate the muscles and see. So a lot of times I'll do appliances with Botox.
amazing. Terry Patrick is asking, from your perspective as a dentist, what are your thoughts about those practicing myofunctional therapy and certification in myofunctional therapy? Do your dental colleagues have opinions about therapists being certified? I did not want to ask this question.
So there are a couple dentists that want a certified.
Yeah, as many dentists want certification, many don't care. It's going to depend on the person.
Yeah, a lot of them don't really care, to be honest with you. I feel like the hygienists care more, and I get it. I mean, I think part of why the hygienists care more is because I feel like we've had to defend our profession for such a long time anyhow, you know, like I personally think that dental hygienist is an obsolete term. We need to change to change the title of a dental hygienist. It needs to be something a little bit more respectable. Like dental hygienist just makes you think you just clean teeth all day. Well, we know that there's a lot more involved with hygiene than just that. So I think that the hygienists just have to defend their profession. So and the fact that they're a licensed professional and all the education they have, and they're licensed healthcare providers. I think that they really want that certification because it's just one more thing that they can, you know, like defend their position with. And I totally get it. I was there. I don't think a lot of the dentists care, to be honest with you. But so I didn't get certified mainly because, you know, to be certified through the IAOM, I had to fly somebody out. I had to have 8 hours worth of patients at the time. I don't know if it's changed. And you know, I could have gotten 8 hours worth of patients. That wasn't the issue. The issue was that, like, I was trying to raise my son, and I was trying to go back to school, and it just really wasn't in my budget to fly someone out. I had had every intention of getting certified and going through that process, but it just never came up to be a good time for me to do that. And so, and also, I mean, I had so much business doing myofunctional therapy that I kind of realized, no, I guess I really don't need it, you know? I'm not saying that it's not a good thing to do, but that's why I didn't, it just never fit into my budget.
I think that the biggest issue, and I say this, I think every week with myofunctional therapy, is that it's not standardized. There are so many different courses out there, and everybody's doing something different, you know, and getting certification is the one thing that is more standardized. And we all know that IAOM is the oldest association, is the only nonprofit. So it has its, you know, its benefits, because, you know, everybody who did get the certification, what they went through, it is actually training. For every single question you have to answer, you have to read research. A lot of people don't. After they do their first training, they don't, you know, you gotta do more than one. You can't just do one course. You have to do several. There's just so much information out there.
Yeah, there is.
It's gonna depend on, you know, where you are with your life. I mean, you become a dentist, so who cares now?
Well, I wanted, you know, the thing is that it would be good for me to be certified so that I can have my course certified. You know, it can be an IAOM certified course, and it's not, because I'm not certified. And so I looked into doing that, and you know, you have to become certified within 5 years of taking your course. And mine is, you know, 15 years old. So I'd have to go back and take another course, which isn't the end of the world. It's not like I wouldn't do that, because I always want to learn more. But now I'm like, I don't know where I can fit that in. So, and in fact, I was talking to Joy Moeller, and she is certified. Well, I can't remember what she said. She did get certified, but I think something lapsed. I don't remember, but her course is not an IAOM certified course either.
Exactly.
So, yeah. And you know, we know how respected, you know, Joy Moeller is in the AOM team. Yeah. So, but she has her own certification program.
Now, yes.
Yeah.
But yeah, it's one of those conversations that we need to have, and I feel like everybody here, we need to fight to make things standardized. That is, I feel like the only way that we're going to get some respect. We all know that patients go to several myofunctional therapists, and we hear this all the time, a dentist saying, oh, they didn't work. Of course, we know that there's patient compliance and everything. But we see things all the time of, people not working on what it should be working on, or not addressing what it should be addressed. I mean, if it's a structural issue and you're trying to push his patient to swallow, if it's a child that's too young and you're trying to push his patient to swallow correctly, you're just not going to get it. So
Right.
there's just so much more involved that these courses do not teach, that we should be talking to each other and trying to figure out, like, how can we get more education?
Mhm.
This is awful, sorry. More education in our field, and how to make things more standardized. I mean, can you imagine if all of us had the same assessment form?
Yeah.
How much different would be to refer a patient?
Mhm.
Every dentist, every ENT would be getting standardized information.
Mhm.
Anyways, this is something that we do need to talk about, and asking everybody that's listening, all of you myofunctional therapists, what can we do to make this a more respected field? It's hard, it's tough. I have a huge sore on my tongue. And it's hitting the screw up there every time I talk or I swallow it stuff. But I'm doing it. I got a diastema. It's split. It doesn't really hurt. It's just sore. But it's one of those things. I have a structural issue.
Mhm.
I used to snore. I used to drool. I used to have all this, be exhausted, mouth breathing. And I did my functional therapy on myself. And of course, it worked. I was no longer mouth breathing at night. I feel like sometimes my mouth would open because I'll be thirsty. But it's a structural issue. I am a 30 millimeter molar to molar. No amount of my functional therapy is going to help me more than it already did. We're all going to hit a wall. My functional helps until a certain point. We're all going to hit a wall. Is this a wall that's a skeletal structure? Is it a soft tissue? Enlargement? We got to find out exactly what it is. What is this, Renata? Treat the oral lesions. Oh, with Butler gum. I need to write that down. It's just one spot. I don't know if you can see it. And it's a huge bump, like it's become like a callus or something, but it's super sore. But anyways, we gotta be able to step back and look at these patients a little bit differently. Most of us are just given this exercise and just go. It's not gonna hurt them. It's gonna help them. And actually, when you step back, there are certain exercises that are not supposed to be done in certain patients. But we have to understand what we're looking at. We have to keep learning. And anyways, I'm gonna get off my soapbox. Thank you, Dr. Anderson, for coming on. Everybody, it's super excited with how inspirational your story is. I mean, seriously, you can't find anybody to do what you need done, and you just go in there and you do it. So congratulations, that is fantastic. How can people reach you? Where are you located?
I'm in Colorado. So I live in Monument, but I work in Denver and Pueblo.
Awesome.
And so I have a website, or you can email me.
Perfect. Make sure you're in the directory. We send patients to people, to other professionals all the time. Let's say, yes, thank you for being a great missionary for the patients in need and for my functional therapy, Dr. Anderson. That's what Terry said. Thank you guys so much. You're wonderful. Everybody have a wonderful night, and we see you next Thursday. We don't have Angela tonight to tell us our amazing things that are going on. So I'll tell you guys real quick. Next Thursday live, we have Dr. Amar Al-Mahdi. I'm not sure if that's how you say your last name. Intro to Airway starts June 1st. And then we have a special course. I moved something. With Dr. Baxter, June 27th from 1 p.m. to 3 p.m. Eastern. That's for Dr. Richard Baxter and Robin Walsh. It's interdisciplinary tongue-tie assessment from form to function. I am going to share those on Airway Circle. You guys let us know if there's anything else that we can do for you guys. And thanks for putting your email down there.
Sure.
On the chat box. Thank y'all. Have a wonderful night. Mwah. We'll see you next Thursday. Bye-bye.
Bye-bye.